Hello, my name is Eric Gantwerker. I am a pediatric otolaryngologist here at Cohen Children's Medical Center, part of Northwell Health System. And today I'm going to be talking about everything pediatric ENT. We're going to talk about ears, noses, and throats, as well as airway and esophageal foreign bodies. I'm going to be showing some images and videos that may be subject to copyright and are being used for educational purposes only. Today we're going to be covering ears, noses, and throats, and a bit of everything. We're going to start by talking a little bit about pediatric ear problems. The first thing I see a lot of patients for is usually earwax problems, and parents often asking what they should do about their children's earwax. And what I always remind parents is that the use of cotton tip swabs in the ear oftentimes is not recommended. We can use cotton swabs on the outside of the ears. However, when you use cotton swabs inside the ear canal, it can actually cause injuries. In fact, there's about 10,000 ear injuries per year due to cotton swabs and almost over 2,000 punctured eardrums from the actual cotton swabs in the ears. Oftentimes, these are not intentional or someone falling on the cotton swab while it's in their ear. And I will say I see these patients quite often. And unfortunately, when you're actually trying to get wax out with a cotton swab, it's more like packing a cannon. And sometimes that earwax can get actually pushed in further due to the size of the ear canal, especially in smaller children. And oftentimes what is happening is you're actually pushing the wax much closer to the eardrum, which makes it actually harder to remove, as well as possibly trapping some water behind the wax that can actually lead to some outer ear infections, which we're going to talk about next. The other is that earwax actually has a very healthy purpose to be in your ear. It actually creates a proper pH balance within your ear canal, as well as fighting off different bacteria and viruses and fungus, and has a very healthy relationship with your ear canal. So don't use cotton swabs. I also have had parents and children sometimes come by asking me about ear candling. I strongly recommend avoiding any kind of ear candling. There are several burn injuries that we see a year due to attempts at actually ear candling, and it doesn't work, and we don't recommend it. Oftentimes, the ear canal is we refer to as a self-cleaning oven. It will clean itself with time. Eventually, the earwax does work its way out and fall out. When the earwax does get clogged, please see your local pediatric ENT, and we can actually clean it out for you using some of our specialized tools. Sometimes your primary care doctor also has some ability to remove it either with flushing or sometimes drops. We're going to move on to ear infections. As we talk about ear infections, it's really important to understand some of the anatomy that we're going to be talking about. The ear is actually split into three different, what we call sections. One is the outer ear, which is the basically the auricle or pinna itself, as well as the ear canal. That stops at the eardrum. Just past the eardrum is what we call the middle ear, which is where the ear bones sit, or what we call the ossicles. Past that, the ossicles actually connect to what we call the inner ear, which is actually where the hearing nerve and the cochlea, which is the hearing organ, is actually located. And that actually is closer to the brain side of the ear mechanism. When we're talking about ear infections, it's really important to understand whether we're talking about outer or middle ear infections. And we're going to talk a little bit about that. We're going to start with outer ear infections. Oftentimes, these can cause pain, irritation, sometimes burning inside the ear, and most of the time they actually cause drainage. And this can actually be seen not just as wax, but more as an infection and lots of swelling inside the ear canal, and can be very, very painful. Oftentimes, we'll talk about how we best treat these, but sometimes people who are actually using cotton swabs or other inanimate objects inside their ear to actually clean out earwax can actually disrupt the normal balance of the ear canal and actually cause scratches and irritations that can sometimes lead to these outer ear infections. In our terminology, we use otitis externa meaning external, and otitis meaning an infection of the ear. This is often colloquially referred to as swimmer's ear because children who get water in their ear can often get predisposed to getting outer ear infections. And however, these are very easily treated, and we'll talk a little bit about that. Oftentimes, when people have outer ear infections, a lot of prescribers try to give oral antibiotics. The good news is oral antibiotics is actually not usually needed for the treatment of outer ear infections unless it's extended outside of the ear canal onto the ear itself or behind the ear in the area surrounding. Oftentimes, we can just treat this with ear drops, usually for a week or so, and these usually clear up quite nicely with just drop therapy. Sometimes we do have to see these patients and clean out the outer ear canal to make sure that we get all the bacteria and all the irritated tissue out, and then treat it with antibiotic drops. We're going to move on to middle ear infections. This is what people most commonly associate with children who get recurrent ear infections. It's really important to know when you are seeing your doctor whether you are having outer ear infections or middle ear infections because we treat them quite differently. Sometimes middle ear infections can extend out to the ear canal, and you can actually have both middle ear and outer ear infections. The important part of middle ear infections is how the fluid is trapped inside the middle ear. So as you see here in this space, the eardrum is on the left-hand side right here, and you can see here the ear bones. We call them the malleus, the incus, and the stapes, which are the ear bones that sit inside the middle ear cavity. On the other side of the middle ear cavity is actually the opening to the inner ear and the cochlea and hearing nerves on the side of the brain. There's really only one escape chute out of the middle ear. We call that the eustachian tube, which you may have heard before, which is down here along the right-hand side. And oftentimes in children, which we'll talk about, the eustachian tube gets a little bit blocked or it doesn't work quite right. And fluid starts to build up in this cavity that we call the middle ear cavity or tympanic cavity. And that can make it prone to ear infections. Again, when you are having outer ear infections, usually the middle ear is protected by an intact eardrum. And so you usually don't have outer ear infections affecting the middle ear. Middle ear infections are actually the most common pediatric bacterial infection, and we know that approximately 2/3 of children will have it by 1 year of age. This is actually a picture of a very infected eardrum. You can see, although the eardrum is intact, there's actually whitish fluid behind it. Usually, the eardrums are quite clear, and we can actually see the inner bones and the middle ear cavity through the eardrum itself. The other thing with children is you can see here that there's actually blood vessels along the eardrum. And oftentimes you'll hear your pediatrician say the ear looks very red and inflamed. It's because basically when there's an infection, a lot of the blood comes and actually turns the eardrum almost red. In some children, actually, when they cry vigorously, even though they don't have an ear infection, their eardrums can turn quite red as well. So it's important to discern whether this is an actual ear infection or the child was vigorously crying during the examination. A lot of healthcare dollars are actually spent on otitis media, which is the middle ear infections. And there's approximately 15 million prescriptions prescribed annually for these ear infections and over $5 billion spent annually. And you can see that takes a very large toll and one of the most common reasons that patients will be brought to see their pediatricians and primary care doctors. It's important to understand when we talk about ear infections, what kinds of symptoms you might see when your child has an ear infection. Usually it's acute onset, meaning that it happens relatively quickly, going from healthy to a sick state. Usually it's a lot of ear pain. Younger kids, because they can't actually tell you they're in pain, will actually tug at their ears, although that is not always universally due to ear pain. So that's something that we talk about when you come to see us as the pediatric ENTs to talk about what ear tugging might mean besides pain. They also occasionally get fevers that usually can herald that there's some kind of infection going on. And again, it all comes back down to the eustachian tube. I call it the escape chute of the ear. And you can see here that this is actually a cavity. And when basically the eustachian tube is not working quite right, that fluid starts to build up. And when that fluid builds up, because the eustachian tube is blocked, fluid starts to accumulate. And in children, there's actually an anatomical or structural difference between the eustachian tube from when they're an adult. Part of the reasons why children are very prone to ear infections is because this tube is actually a little bit more collapsed and it's much more horizontal or sideways in orientation, as opposed to as adults where this actually has gravity helping it. This tube actually brings fluid from the ear into the back of the nose. And this is actually right in the back of the nose where children often have adenoid tissue, which is something that we'll talk a little bit about later. But usually, because this tube isn't working quite right, then children can have water that builds up inside the middle ear, and it makes it prone to bacteria, just like a pond water or water that's still. And when that bacteria sets in, it can actually cause ear infections. And oftentimes, these are well treated and very easily treated with oral antibiotics because there's no other way to get antibiotic medication into that space when kids have intact eardrums. Oral antibiotics is usually the mainstay of therapy. And we can sometimes give multiple rounds or escalating, as we call it, antibiotics. And that's when we start talking about ear tubes and things like that. Oftentimes, we see patients in our office who have had fluid that is either before or after an ear infection. It's important to understand that this fluid, as you can see, is actually clear or almost amber colored, which means that it's actually what we call serous, which means that it's actually not likely infected. The important part of this is that sometimes after your child has had an ear infection, this fluid may stay around for a few days to a few weeks. Again, remember that the entire reason why kids are prone to ear infections is because that eustachian tube, that escape chute out of the ear, is not opening. And thus, fluid has a hard time getting out of the ear canal. Eventually, it does. You have felt eustachian tube problems when you've had a cold and your ears get stuffy. That's exactly what your child is feeling. And in fact, we'll talk a little bit more about when your kids get colds, they actually get this fluid as well. It doesn't mean that that fluid is infected and doesn't mean that they need oral antibiotics because, again, this is a mechanical or structural problem as opposed to an infectious problem. Oftentimes, when we are on a plane or feeling like our ears are feeling stuffy, we'll actually try to Valsalva or basically try to push pressure in our ears to open up that eustachian tube, or we sometimes chew gum or swallow, and those types of things actually open up the ear canal, the eustachian tube rather. I don't recommend giving gum to your child, however. And really, what we have recognized is this is sort of what we call a continuum, meaning that most children start out with a normal ear canal, and then it starts to actually have some pressure to build up. And that's that pain that children actually feels, the pressure building up inside the ear, because that eustachian tube, which is also what we call a pressure equalization, that doesn't allow for the pressure to normalize. You felt this again on an airplane when the pressure outside was not equal to inside and you actually felt pain. This is sort of the beginning possibly of an ear infection. Then the fluid starts to actually fill into that space and the eardrum starts to bulge, and then the fluid actually gets infected. Just as this progresses from left to right, it also often progresses from right to left. As the infection clears, you still have the fluid. Eventually, the fluid will clear and eventually it'll go back to normal. It just takes a little bit of time. Unfortunately, I see a lot of parents and prescribers try to give allergy medications to young children, as well as multiple rounds of antibiotics when they have this fluid that's sitting there. Again, because this is a mechanical problem, allergy medications often don't work in young children, and there's no evidence that any antibiotics would actually hasten the resolution of that fluid. So oftentimes we don't recommend these when kids have had prolonged fluid. Oftentimes we just recommend a little bit of time. And eventually that, just as you have a cold, eventually your ears and inflammation will calm down, that eustachian tube will open, and eventually they'll come out. Occasionally, we do prescribe allergy medications to those children who have allergies. And sometimes we prescribe nasal sprays to actually shrink down some of the tissue that may be blocking the eustachian tube, including the adenoids. And we'll talk a little bit about that later. Again, as I alluded to previously, when children get colds, just like adults, they get fluid in their ears and oftentimes can present with ear pain and tugging that almost looks like a bacterial infection. However, on examination, we actually see this fluid that is there as it relates to a cold. Oftentimes, we see that actually greater than 90% of kids will have fluid before they become a school-age child. Again, because this fluid is not infected, oftentimes these patients do not need antibiotics or allergy medications. They just need a little bit of time for these colds to run their course, just as we would in you or I as adults. Again, allergy relief and oral antibiotics will not hasten the resolution of that fluid in young kids. We do sometimes use it in slightly older kids because there might be an inflammation of the adenoid component to the infections, and that's where we might use those. Importantly, a lot of parents ask me, when is it time for ear tubes? There's really two major indications that we recommend doing ear tubes. Ear tubes essentially is a procedure where it's briefly under anesthesia. It's usually relatively quick. The children does not feel anything and usually wakes up and goes home the same day. Essentially, what we do is we make a small opening in that eardrum and we drain out that fluid that is sitting in that middle ear cavity and put a very small plastic tube or sometimes metal tube that will actually keep that small hole open. And really, the reasons why we do that is often if that fluid sticks around for a long period of time, we usually say about 3 months, then the likelihood of it coming on its own, that eustachian tube starting to become healthy, usually is not going to be the case. And oftentimes we want to get that fluid out because eventually the children can have hearing and speech outcomes if that fluid is left too long, especially during those critical periods of speech development. The other is kids that have recurrent ear infections. So they, however, don't have fluid that sticks around between the ear infections. However, they're getting repeated ear infections. There's a lot of risk factors that we talk about that may make kids prone to recurrent ear infections, including daycare and things such as that. Interesting enough, during COVID-19, we actually saw a dramatic decrease in the amount of ear infections that are being referred to pediatric ear, nose, and throats across the country. We think that, again, is because of that the limitation of viral spread and the limitation of daycares and things where children are actually sharing different viruses amongst themselves. That often is part of the normal immune process. So we actually have seen a decrease in the number of ear infections. Importantly, we also look always for any kind of child that's had recurrent ear infections when you come to see and be evaluated by the pediatric ENT to see if that fluid is still there, to see if they're healthy, and to see if their hearing and speech is normal. This is actually a hearing test that your doctor may prescribe and allows us to see whether your child is hearing normally or not. In this example, the audiogram is actually normal and the exam is normal. So it may not be uncommon for your pediatric ENT to recommend against ear tubes if they feel like their recurrent ear infections are either too few or they're well treated, or there's signs that the eustachian tube is working. Because remember, if the eustachian tube is working, that fluid should come out. And when you're evaluated, there should be normal ear exam. Also, when there's a little bit of fluid in your ear, just as you experience when you have a cold, sometimes your ears get stuffy and it's hard to hear. Your child is the same. When there's fluid there, there's actually hearing underwater, and it actually can cause a little bit of a temporary hearing loss because the fluid is there. And once the fluid is gone, their hearing comes back to normal, which is oftentimes why we'll actually do a hearing test during the examination when you come in to see your pediatric ear, nose, and throat doctor. Here's an example of what those ear tubes look like. They're actually very small. They're almost the size of the head of a pen. They're approximately 1.5 millimeters. It depends on the inner diameters. They can actually be wider or smaller. But essentially what they do is they sit inside the eardrum and allow that fluid somewhere else to go. Because the little escape chute, the eustachian tube, is not working, it allows the actually fluid to come out of the ear. That has several implications. Number one is that because the fluid can come out, oftentimes it doesn't actually accumulate and it doesn't cause hearing problems, as well as it allows fewer ear infections to happen because you don't have that water or fluid just sitting there waiting for bacteria to grow. The other is because the fluid actually can come out, we actually can get fluid in. So we often prescribe ear drops for patients who have ear infections when they have ear tubes in place. So it also makes it easier to treat because children won't need oral antibiotics anymore because we can just do ear drops that go straight through the actual ear tube itself into the middle ear where that infection happens. And in fact, we can get concentrations of antibiotics straight to the source, almost 10,000 times the concentration of what we would with oral antibiotics. So it's actually a very effective solution for treating ear infections in children with ear tubes. The other is children often have less pain with the ear tubes because, again, that pain comes from pressure building up inside the ear or fluid building up inside the ear because the eustachian tube won't open. Well, that pressure won't build up because the tube is there. There are complications with tubes that we'll talk about and your pediatric ENT will talk about, including sometimes there might be a small hole left over. Sometimes they come out too early or stay in too long and need to be removed. You can talk to your local pediatric ENT about that before you endeavor on having your child undergo ear tubes. We're going to move on to throats. So, a lot of the second most common patients and parents come to see me is because of problems with their tonsils or snoring. Oftentimes, it's on us to decide and determine whether the patient is just snoring or if there's something more in depth going on. We often talk about sleep apnea. Just as an adult, sleep apnea can happen in children. We treat it slightly different and we work it up slightly different, and we'll talk a little bit about that. It's important to know, just like ear infections, there is a continuum of snoring from normal breathing at night to mild snoring to regular snoring, and all the way up through different types of obstructive sleep apnea. Again, obstructive means that something's blocking the normal windpipe. Anywhere from the nose to the throat, all the way down to the lungs, can actually have areas of blockage. And that's why we call it obstructive sleep apnea. Apnea literally means stopping breathing. Oftentimes, when we are diagnosing patients with sleep apnea, we will ask, "Is your child look like they're struggling to breathe at night when they sleep? When you hear the snoring, or actually seeing gasping or pauses for several seconds and catch up breathing after they start breathing again?" Those are some of the signs and symptoms that we go by to determine if your child actually has some elements of sleep apnea, or what we call sleep disordered breathing, which means that the obstruction is actually causing problems, but we're not sure if it meets the criteria for sleep apnea. Importantly, in children, we actually have two different types of symptoms that we look for. We look for both daytime symptoms and nighttime symptoms. In adults, often people with sleep apnea can be described as being very tired or fatigued or falling asleep while doing normal activities or even quiet activities. And those can sometimes happen in children as well. And we talk about daytime sleepiness, concentration issues, irritability, sometimes hyperactivity, which we'll talk about in a second, as well as taking afternoon naps when they're a little bit older. Oftentimes, we actually do see early morning headaches in children who are not sleeping well as well. But oftentimes, children actually have the hyperactivity type of symptoms that might be slightly different from the adult counterparts. The other is we'll ask parents, do you hear these loud noises, this loud snoring? How often does it happen? Have you seen your child actually pause breathing or have several seconds of what we call apneas? Are they choking or gasping for air? Are they relatively restless? Are they changing positions a lot? And also, do they do frequent visits to the bathroom? In younger kids, we actually see kids that are actually bedwetting, and we'll talk a little bit about that in a second. Importantly, this is probably one of the most surprising statistics that I ever tell parents, is that 50% of children diagnosed with attention deficit hyperactivity disorder may actually have pediatric sleep apnea. This is one of the major indications for me to see patients when parents really don't realize that their child is ADD or ADHD and almost starting on medications. Because children are not sleeping very well, they get very irritable, short-tempered, have temper tantrums, and oftentimes have problems learning in school. I often ask parents how their child is doing in school, if their teacher is complaining about them having hyperactivity or irritability or acting out, things like that. That's not to mean that every child that has these types of symptoms had sleep apnea, but I do recommend seeing if your child has some other signs and symptoms of sleep apnea that may make you believe that it may be contributing to the problem. The other thing that we often see is children with bedwetting. These are kids that are otherwise potty trained and should not be having accidents at night, or a little bit older, who are continually having bedwetting problems. It's not uncommon these patients have already seen a urologist or a urinary systems specialist or a kidney specialist to find out if they have problems, and sometimes even starting on medication. Just like the ADHD, it doesn't mean that every child that's bedwetting is having problems with sleep apnea, but it's important to investigate if your child is having snoring and having problems sleeping at night and having some of the other signs and symptoms that we get evaluated. I have personally seen patients who had this bedwetting problem, had the problem with their obstructive sleep apnea fixed, and the bedwetting problem went away. Not to say that that's guarantees any outcomes, but it's definitely raises the suspicion that you should get it checked out if you have concerns. Again, we talked a little bit about how do you know if it's snoring or if it's true sleep apnea. Oftentimes, we go through those daytime and nighttime symptoms with most parents. If we're pretty convinced that there is a problem and and the exam shows some signs that there may be tissue that may be blocking the airway, then sometimes we talk about treatment pathways. Oftentimes, if we're really not sure, then we get something called a sleep study. The sleep study is where your child sleeps overnight in a laboratory hooked up to some monitors that will actually watch for either slowing down of breathing or pauses in the breathing that actually leads us to believe they may have sleep apnea. This is a relatively objective test, meaning that it tells us with pretty high degree of certainty on that evening if your child had sleep apnea or not. And we then use that as part of our spectrum of data that we will decide what is the next best step for your child. Sometimes, if children have had previous surgeries to fix obstructive sleep apnea, we'll actually get repeat or follow up sleep studies. Not every child needs a sleep study to determine whether or not they have sleep apnea. Again, we can often go by some of the symptoms and signs that are pretty telltale of whether your child has sleep apnea or not. We reserve sleep tests for certain populations, which your pediatric ENT will talk to you about. Oftentimes, parents ask me, what happens if I don't treat my child? If your child has known sleep apnea, and especially moderate to severe sleep apnea, we don't recommend waiting. We do have some ongoing studies right now as to whether children with mild sleep apnea or even what we call sleep disorder breathing, which is we have suspicion for sleep apnea but aren't sure yet, and to determine whether or not those children grow out of their sleep apnea, at what point, and what effects it may have had on them. We do know that moderate to severe sleep apnea can cause problems with learning and behavior. And so that's some of the symptoms that we definitely see with kids who are struggling in school. They're acting out. Oftentimes, they're getting diagnosed with ADHD and getting started on medications. Those are the kids that we feel like we may have some solutions for to help at least minimize or help some of those symptoms, and it's worthwhile getting checked out. Long term obstructive sleep apnea, especially in adults that we see more often than kids, is they can have sometimes heart and lung problems because your body's working so hard to breathe against that blockage that sometimes the heart and actually lungs can actually have some changes because of that. When you get evaluated by your pediatric ear, nose, and throat, as well as your pediatrician, there's several areas that we look at to see where the blockages might be in your child with sleep apnea. Oftentimes, we look at the tongue, we look at the tonsils, which we call the palatine tonsils or the tonsils next to the palate, as well as the adenoid tissue. The adenoid tissue is probably the one area that parents are least familiar with. Tonsils you're very familiar with because that's where kids get strep throat. Those are the balls of tissue in the back of the throat on either side. And your pediatric ear, nose, and throat doctor will tell you if those are enlarged and what that might mean. The other is the adenoid tissue, which is behind the nose, where the nose enters into the back of the throat and eventually down into the airway. That is another site of potential obstruction. There are several sites that may be obstructed. However, these are the most common in children. Oftentimes, the adenoid tissue can be described as if you just look above the palate, there's actually this area right here where the nose empties into the back of the nose and then down into the throat. And here's the opening to the airway. Here you see the tongue and you see the soft palate. This is actually the uvula or the little hanging thing in the back of your throat. And oftentimes, when we talk with parents about children with sleep apnea, we talk about both the tonsils and the adenoids as possible sites of obstruction. Sometimes we do recommend having a tonsillectomy and adenoidectomy. So that's actually removing or reducing the amount of tissue in the tonsil area and in the adenoid tissue. And oftentimes that relieves that area of blockage and can be quite successful in preventing and treating rather sleep apnea in children. We can talk more about that when you actually see your physician. The success rate for having your tonsil and adenoids removed is actually quite high. In otherwise healthy children, we actually see approximately 80% of children not needing any other intervention to treat their sleep apnea. Unfortunately, we have a large childhood obesity problem in America that has been getting worse with time. And now we are seeing children who are obese actually have a higher rate of residual sleep apnea after their tonsils getting removed. This 80% number then usually drops down to about 50% success rate. Oftentimes paired with weight management and weight loss strategies, we can improve the childhood sleep apnea and quality of life. Sometimes we will recommend CPAP, which is continuous positive airway pressure. Just like in adults, children can have this as well once at a certain age. Your pediatric ear, nose, and throat or your pediatric pulmonologist will talk to you about CPAP to see if that's right for your children. Sometimes children cannot undergo tonsillectomy and adenoidectomy for various reasons, or they've already had it done and they have persistent sleep apnea. Those children are often we referred to get CPAP therapy, which can be effective at treating the problem. We're going to move on to sore throats and strep throat. Oftentimes, I see parents and patients who have had recurrent strep throat and they've had several rounds of antibiotics and are missing a lot of school. It's important to understand when a strep throat is actually bacterial versus viral, which we'll talk about in a second. Unfortunately, the exam can give you some instructions as to whether it might be viral or not. The time course is usually a slightly better measure of when this might be viral or bacterial. Oftentimes, we say the tonsils during a bacterial infection are very red and swollen, may have white spots on them. However, this is not universal. Some patients have white spots in their tonsils as normal, which we call tonsil stones. And so that actually is not a great measure of whether it's bacterial or viral. Sometimes the redness or degree of redness or degree of pain can sometimes be an indication, but again, that's not universal. It's important to know that essentially, of sore throats in children under the age of 5, that 95% of them are viral, meaning that they will not respond to antibiotics. Only 5% of children under 5 will actually have bacterial throat infections necessitating antibiotics. Well, as we get to the 5 to 16-year-old range, usually the viral component is approximately 70% and about 30% bacterial. So in those cases where bacteria is predominant or it's cultured through a swab, oftentimes antibiotics are prescribed. So signs and symptoms, usually when we're having a strep throat, it doesn't always include the cold symptoms like a cough or runny nose or hoarseness. Those are often signs of a viral infection that sometimes is leading to the sore throat. Occasionally, people can have many other reasons for sore throat, including nasal allergies and acid reflux. So it's important to get evaluated to understand whether your child actually has strep throat and whether they're indicated for oral antibiotics. There are some complications of strep throat, including problems with the heart problems as well as your kidneys. And sometimes the infection actually goes outside of the tonsil and actually cause some abscess or infection pockets that sometimes need to be treated more aggressively. It's important to know that when we have had recurrent strep throat, we usually recommend getting evaluated to see how often it's actually happening. So these are well-documented, independent episodes of strep throat. And usually what we go by is the 3-5-7 rule. So we call recurrent strep throat 7 episodes in 1 year, 5 episodes per year for the last 2 years, or 3 episodes for the last 3 years. And those are what we call recurrent strep throat. And that is where we talk about possibly removing the tonsils as a potential solution to helping with those recurrent streps. We also look at patients who've missed a lot of school, may have antibiotic resistance or allergies because they get harder and harder to treat for the pediatricians and the primary care doctors. And so we oftentimes discuss tonsillectomy for those patients as well. We're going to move on to airway and esophageal foreign bodies. This is actually a very important topic and something I often talk about. And there's a lot of different task forces that are looking at different things that children aspirate or swallow. Unfortunately, it's a leading cause of accidental death among infants and the 4th leading cause of death in preschool children. There's approximately 17,000 emergency room visits per year in children under 14 for airway and esophageal foreign bodies. There's a very great program that I recommend you checking out, which is Be Smart, Don't Choke, which is out of the University of British Columbia. They have a very good website, and some of these were taken from that website. These are the most common things that we see children actually aspirating or swallowing. Children explore the world through putting things in their mouth, and that's a very common thing. It's very important to remain vigilant and understand what can and cannot go into your child's mouth and what types of things they might be putting in their mouth that may be dangerous. Probably the most common thing I see is coins. Children often like to put coins in their mouth, and unfortunately, some of the coins are too big to actually be swallowed and then get stuck into the food tube or esophagus. Nuts and seeds are often seen as well, sometimes going down into the wrong pipe, as we say, in adults. And it's actually very common in adults to actually aspirate nuts and seeds, including peanuts, which can be quite irritating to the lining of the lungs. In other countries, oftentimes fish bones and chicken bones and things as the such can be swallowed and get caught inside the airway or inside the throat or the esophagus. Raw vegetables is probably a very common thing. Carrots can be very, very dangerous. We'll talk a little bit about that. Raw fruit, just like raw vegetables, can sometimes be cause problems. One of the common things we see about raw fruit and raw vegetables is that sometimes the outer surface can be very tough, and because children don't have molars, they can't cut through that type of really rough outer tissue or outer fiber like grapes have, or apples, things like that. And when children actually bite down, it actually causes the items to propel backwards before the child is ready to swallow. Unfortunately, hard candy can be given to kids and sometimes cause a problem. Again, we strongly recommend against that. Popcorn kernels go in pretty much every orifice I've seen: the nose, the ears, the throat, all of these different things. Popcorn kernels are actually quite common for kids to actually put inside their nose and ears. And oftentimes we see toys, children who are swallowing toys, and some of these can actually cause major damages to the esophageal lining or the lining of the throat. These are what we would consider the most lethal. So I strongly recommend vigilance with your child when these types of items are around. Hot dogs, again, because they have a very hard surface, can sometimes cause major problems and actually be aspirated and cause major damage and problems with your child breathing. Grapes, again, as I alluded to before, have that rough outer tissue that sometimes can cause problems with biting it and swallowing, which is often why we recommend cutting up hot dogs and grapes into much smaller pieces. Disc batteries are probably one of the most dangerous things I see because not only do they actually cause blockages themselves, but they actually can conduct electricity if swallowed and put inside the esophagus, which we'll show a little bit later. And that can cause major damages to the structures of the throat and the esophagus that are sometimes non-repairable. Meat chunks, sometimes we can see if the meat is too big. This happens in adults as well. Marbles, obviously very, very scary. Marbles, beads, anything that has an outer surface, even if it's not organic, can cause major obstruction problems and unfortunately lead to death. Pop balloons, we strongly recommend avoiding having your child play with balloons or even the gloves inside the doctor's offices, because these pieces of tissue or these pieces of plastic can actually block the airway and cause problems breathing, and sometimes can lead to long-term damage and sometimes even death. Dried beans and legumes, including peanuts. Peanuts are actually probably one of the worst that I see because it causes actually very bad irritation inside the lungs. And when it gets aspirated, it actually causes major inflammation that sometimes causes major problems getting it out, which is always the hard part for me. Obviously, we've seen a lot about the little prepackaged different detergents, and being very, very careful with children around these because of a multitude of reasons. Obviously, there's the plastic component, but also the liquid inside, especially if it is caustic, can actually cause burns inside the throat and down through the esophagus that can lead to major damages and sometimes even narrowing of the esophagus as it heals. Mini magnets, if they're especially if they're swallowed in multiples, can sometimes cause abnormal connections between certain organs and cause a lot of problems. So again, be very careful about any types of these things around your child. This is actually an x-ray of a child who had swallowed a coin. And so you can see here, actually, here's the outline of the heart. Here's actually the collarbones. And here is the lung fields with the ribs. You can see here that this coin is actually blocked at the opening into the esophagus. The esophagus goes all the way down and connects down into the stomach, which is down here. And oftentimes we have to go in and take these out. But one of the things I want you to recognize is, how perfectly round this is. And this is again, a coin, as opposed to this, which is actually a disc battery. You can see actually they look very much alike on an x-ray. You can see, again, this being stuck in right into the opening of the esophagus. Again, here's the lung fields with the ribs, and here's the esophagus, the heart, and here's all the way down into the stomach. And the reason why these are emergent is every second that goes by, this is actually causing damage to the lining of the esophagus. You can see here that there's actually what we call a double halo, which means that there's actually a way to tell a difference between this and coins. But I will tell you, in practice, this can be quite difficult. Usually coins, we can wait because it's not going to cause any damage. And unfortunately, I've seen where kids actually swallowed disc batteries that were read as coins, and the child waited to get attention retention and actually cause major permanent damage to their esophagus. I can't tell you enough to avoid getting any kind of disc batteries from remotes, hearing aids, any of those things out of your child's hands and locked away if you do have them. And be extremely careful about any remotes that kids can open that may have these disc batteries in them because they cause major damages. There are major task force across the United States and the world to try and get the industry to actually change the labeling on these, and so that when an x-ray is actually taken, we can tell right away if this is a disc battery or a coin, but it often is actually very hard to tell. Here again is a picture of a disc battery, and you can see here that it actually looks like two different things. Sometimes kids can swallow two coins and can actually look like this as well. But again, the delay in diagnosis and definitive treatment can cause major long-term outcomes and sometimes even death. And as you can see here, this is unfortunately a child who had a disc battery. You can see here on the x-ray. And here actually is the damage to the esophagus. You can see here actually is the disc battery itself. And you can see all the damage that is happening. And this, unfortunately, can lead to permanent damage and sometimes narrowing and problem swallowing. We're going to move very briefly to noses and then we'll be done. Disc batteries can be in the nose as well. Again, this disc battery is inside the nose. And again, because it actually starts to conduct electricity, because of the opposing surfaces that are actually helping conduct the electricity, can cause permanent damage. Unfortunately, I actually had a child who had brown drainage from the nose for several days, and they thought it was an M&M. However, as it went on and mom noticed that there was a foul smell to it, she brought the child to see me. And sure enough, there was a disc battery in there that is actually causing major damage inside the nose and sometimes can actually lead to permanent holes in the nose like this one here. As you see here, this is the bone and cartilage that separates into the two sides. We call this the septum. And you can see here that on the septum, there's actually a hole through and through from one side to the other. And this was caused by a disc battery that was allowed to be in there for too long that actually caused this permanent hole. We then try to fix that hole, but it doesn't always work. And sometimes children are left with these permanent holes from these disc batteries. It's important to know that anything inside the nose, including disc batteries, should not be attempted to be dislodged. We recommend having an expert take these out because these can very quickly become airway foreign bodies or esophageal foreign bodies that can cause damages in and of themselves. And we don't recommend blowing on your kid's nose to try and remove the foreign body because that again can cause them to aspirate it or swallow it and cause further damage. With that, I thank you. My name again is Eric Gantwerker. I'm a pediatric otolaryngologist at Cohen Children's Medical Center, part of the Northwell Health System. Thank you so much for joining us.